Welcome to the deep dive. This is where we take your source material, maybe articles, research papers, or like today, those really crucial revision notes you've sent us.
Yeah, and we dive right in.
We jump in, pull out the absolute most important bits, the high-yield insights.
Think of it like a focus chat, getting you straight to the core info you need to know.
Exactly, giving you that fast track right from the stuff you need to master. So for this deep dive, we're tackling conductive hearing loss.
Okay.
And we're using a set of MSRA revision notes that one of you actually shared. That's our map today.
Right, and our mission really is to unpack these notes together. We want to help you spot the key facts, see how things connect, and just really get the core knowledge solidified.
Yeah.
It's all about making your revision clearer, more effective, using your material as the base.
Perfect. All right, let's dive in then, starting right at the beginning, like your notes probably do. What exactly is conductive hearing loss? What's the basic definition from these notes?
Well, the core idea in these notes is pretty straightforward. It's a type of hearing impairment, obviously.
Okay.
But the key, according to the material, is that the problem isn't, the inner ear processing the sound or the nerve sending signals.
Right.
No, it's an issue getting the sound waves to the inner ear in the first place.
Ah, okay. So physically getting it there.
Exactly. Your notes highlight it's because of some kind of blockage or maybe a dysfunction in the outer ear or those middle ear bits. Essentially, the path for the sound is interrupted somehow. The notes use the phrase, reduced sound transmission to the cochlea.
The cochlea, that key bit in the inner ear.
That's the one, where sound energy gets turned into nerve signals, so if less gets there.
You get hearing loss. It's like a traffic jam maybe on the way to processing plant. Sound just can't get through properly.
That's a good way to put it.
Yeah.
And the notes, they do briefly contrast it with sensor neural loss, right? Which is more like a problem with the plant itself or the wires from the plant.
Got it. That distinction seems pretty crucial.
Oh, absolutely. Understanding where the breakdown is, outer, middle, or inner ear, dictates everything else, as your notes really emphasize. Causes, tests, management. It all flows from that.
Okay, clear definition set. So if it's this sort of mechanical issue getting sound in, what kind of things do these notes say actually cause it? What are the main culprits, the etiologies?
Yeah, the notes give a good list covering the kind of things you'll likely see. Right up top is simple cerumen impaction.
Just earwax.
Just earwax buildup, blocking the canal, very common. Then there's otitis media, middle ear infections. The notes mention these frequently, especially, in certain groups.
Okay.
You'll also see tympanic membrane perforation listed.
A hole in the eardrum.
Exactly, often from an infection getting bad, or sometimes trauma. And there's otosclerosis.
Otosclerosis, that's the bone growth one.
That's the one. Abnormal bone growth affecting the stapes, one of those tiny little vibrating bones in the middle ear. Stops it transmitting sound properly.
Ah, the ossicles. Malleus and Otitis, stapes. I remember those.
Those are the ones. The notes also mention a few others, like fluid building up behind the eardrum. That's a middle ear effusion.
Sometimes called glue ear.
Yep, glue ear is the common term. Also, structural issues someone might be born with, tumors, though less common, or physical trauma to the ear.
Wow, okay. So it ranges from, like you said, simple wax plug to much more complex stuff.
It really does, a whole spectrum.
That makes sense given the variety.
Yeah.
Now, based on those causes, who does the material suggest is more likely to run into this? What are the risk factors highlighted in these notes?
The notes list a few key risk factors to keep in mind. Having recurrent ear infections is definitely a big one.
Right. Makes sense if it damages the eardrum or causes fluid.
Exactly. Interestingly, loud noise exposure is listed. Now, you mostly think of noise causing sensorineural loss.
Yeah, damage to the inner ear.
Right. But severe acoustic trauma, like a blast, could potentially cause conductive damage, too, maybe dislocating those little bones or perforating the eardrum.
Ah, I see.
Occupational hazards are mentioned, too, maybe related to trauma or chronic irritation in the ear canal. And then there are medical conditions like otosclerosis, which can run in families, so genetics is a factor there.
A family history.
Yep. And just direct ear trauma, of course.
Yeah.
So when you're talking to a patient with hearing issues, thinking about these risk factors, asking about them. It's really important. The notes give you those prompts.
Definitely good clues for history taking. Now, this is where it gets really interesting for me. The how. How does this actually happen physically? What's the pathophysiology according to the notes?
Right, the mechanism. The notes really boil it down to that disruption of the normal sound pathway we talked about.
Okay.
So sound waves come in, travel down the ear canal, hit the eardrum, make it vibrate.
Then the little bones amplify it.
Exactly. The ossicles in the middle ear amplify and transmit that vibration across to the inner ear. Conductive hearing loss just means something's interfering with that process. The notes say it could be an issue with amplification in the outer ear, but usually it's a problem with transmission through the middle ear system, the eardrum, the ossicles.
So the mechanics are off somewhere in that chain.
Pretty much.
Yeah.
Whatever the specific blockage or malfunction, the end result is the same. Less sound energy, and probably less clear sound energy, makes it to the cochlea. And that reduction in input is the hearing impairment.
It's a mechanical breakdown stopping the sound getting through effectively.
Yep.
So if someone comes in complaining of hearing loss, how do these notes suggest we figure out if it's conductive versus something else? What are the key differential diagnoses mentioned?
Yeah, making that distinction is job number one, really, for management. Your notes flag this clearly. The main differential to consider is sensorineural hearing loss.
The nerve type deafness.
The nerve or inner ear problem, yeah. Then there's mixed hearing loss.
Which is to both.
Exactly, where you've got elements of both conductive and sensorineural loss happening together. And the notes also just remind us to think about other things causing ear symptoms that might, seem like hearing loss at first glance, maybe just wax, or other temporary issues. But the crucial point here from your notes is sorting out the type of loss. That's the first big decision point.
Right, that directs the next steps. Okay, let's zoom out a bit. What's the bigger picture? How common is this? Do the notes give any sense of the epidemiology, maybe specifically for the UK?
They indicate the prevalence isn't like one single number. It does vary quite a bit.
Depends on the cause.
Depends on the cause, definitely, and the age group you're looking at. But it's explicitly mentioned as being more prevalent in children.
Ah, okay. More common in kids.
Which fits perfectly with the common causes, right?
Yeah.
Earwax buildup happens in kids, and middle ear infections, otitis media, are incredibly common in young children.
Yeah, every parent knows about those.
Exactly. So while it can affect anyone, any age, your notes really underscore that you'll see conductive loss particularly often in your pediatric patients.
That's a key takeaway for revision then. Right, let's get practical. How would someone actually notice they have this? What signs and symptoms are listed in the notes? What might a patient report, and what might we see?
Okay, clinical presentation. The notes give a pretty clear picture. The most common thing is probably that feeling of muffled hearing, or just that sounds seem quieter, reduced sound perception.
Things sound dull.
Yeah, or distant. Patients might say they struggle hearing faint sounds. They might also mention a feeling of fullness or pressure in the ear.
Like it's blocked.
Exactly. And if infection is involved, obviously, ear pain otalgia, as the notes call it. Tinnitus is also on the list.
That ringing sound.
Ringing, buzzing, yeah. Now, here's a really interesting point mentioned in the notes, kind of a classic sign sometimes.
Oh, yeah. What's that?
Hearing might actually seem better in noisy places.
Better in noise. That sounds backwards.
It does. It's called the paracusis of Willis, though the notes might not use the fancy name. The idea is, in a noisy room, everyone talks louder, right? Which helps overcome the conductive block.
Ah, okay. The input level is higher.
Exactly. And maybe the background noise masks other sounds, letting them focus better on the louder speech, possibly even hearing some through-bone conduction. It's a specific clue the notes point out.
Definitely one to remember for exams. Any other associated symptoms?
The notes also list vertigo, though less common, and sometimes paradoxically, the person might speak quietly.
Why quietly?
Because their own voice sounds loud to them due to the bone conduction being exaggerated relative to the blocked air conduction. They can't gauge their volume well. And as we mentioned with otitis media in kids, look out for systemic things too. Fever, being generally unwell, irritable.
Right, the whole picture. Okay, so we've got these symptoms. What tests can we do right there? Bedside tests based on the notes.
The notes cover the standard bedside hearing tests. First, there's the whisper test.
Simple screening.
Yeah, pretty basic. Whisper numbers of phrases, mask the other ear, see if they can repeat it. Good initial check.
Okay. Then the tuning forks.
Then the tuning forks, yes. Usually a 512 hertz one. The RIN test is key.
RIN compares air and bone conduction.
Exactly. You strike the fork, put it on the mastoid bone behind the ear that's bone conduction. Ask when they stop hearing it, then quickly move it next to the ear canal that's air conduction. Normally, air conduction is louder or lasts longer than bone, AC, BC.
Not in conductive loss.
In conductive loss, it's the opposite. Bone conduction is better than air conduction, BC, AC. The notes really emphasize this finding. RIN negative, they might call it.
Got it. BC greater than AC. And the other one, Weber.
The Weber test. Strike the fork, place it firmly on the middle of the forehead or the top of the head. Ask where they hear the sound left ear, right ear, or middle.
And in conductive loss?
In conductive loss, the sound lateralizes, meaning it seems louder in the affected ear.
Louder in the bad ear. Why is that?
Because the conductor block stops ambient room noise from getting in via air conduction and masking the bone-conducted sound in that ear. So the bone-conducted sound from the fork seems relatively louder compared to the good ear, where normal hearing via air masks it a bit. Again, a really key finding highlighted in your notes.
Okay, Rin negative, BCAC, and Weber lateralizing to the affected ear. Those are classic conductive findings. Very high yield.
Definitely. Those bedside tests give you a strong pointer.
So beyond the bedside, what else do the notes say about investigations to really confirm it and find the cause?
Right, confirming it. Your notes explain it's about putting everything together, the history, the physical exam findings, especially those tuning fork results, and then the formal audiological tests.
And the physical exam includes looking in the ear.
Absolutely crucial. Otoscopy, using the otoscope to get a good look down the ear canal at the tympanic membrane, the eardrum.
What might we see?
Well, the notes list specific things linked to the causes. You might see the obvious wax plug cerumen impaction.
Easy diagnosis then.
Sometimes. Or you might see signs of acute otitis media, a red, maybe bulging eardrum, or a visible hole, a perforation.
Right.
Or signs of effusion, that glue ear.
Yeah.
Maybe you can see fluid levels or bubbles behind the drum.
Okay. What about for otosclerosis? Does the eardrum look normal?
Often it does, yeah. But the notes mention a potential sign, though you don't always see it, called Schwartz's sign.
Schwartz's sign.
Yeah, described as sort of a reddish-blue blush seen through the eardrum, apparently due to increased blood flow related to the bone changes. Something to be aware of, even if the drum mostly looks normal.
Interesting. So otoscopy gives clues. What about the definitive tests?
That's the audiology. The notes highlight pure tone audiometry. That's the test where the patient wears headphones in a booth and signals when they hear beeps at different pitches and volumes.
That graphs out their hearing thresholds.
Exactly. It clearly shows the type of loss conductive shows that gap between air conduction and bone conduction thresholds, and also the degree, how severe it is. Tympanometry is also vital.
What does that measure?
It measures how the eardrum moves in response to changes in air pressure in the ear canal. It's great for checking middle ear function, tells you if there's fluid back there or if the Eustachian tube isn't working right or if the eardrum is stiff.
Okay, so audiometry and tympanometry are the main ones. Any others?
The notes mention imaging, like CT or MRI, might be needed sometimes. Not routine, but maybe if you suspect a structural problem, a tumor, complications from infection or trauma. And they add a little point that sometimes you might need more specialized subjective or objective tests if the picture's still unclear after the basics.
Right, a comprehensive approach. So we've got the diagnosis, we've hopefully found the cause. What do the notes say about managing conductive hearing loss? What are the main goals and the options?
The management strategy, according to your notes, is pretty logical.
Yep.
2 main goals. First, deal with the underlying cause if you can.
Treat the infection, remove the wax.
Exactly. And second, find ways to improve the sound transmission to the inner ear. The options really depend on what that underlying cause is.
Makes sense.
So the notes list things like, well, earwax removal for impaction, antibiotics for bacterial middle ear infections, but with specific criteria mentioned.
Not just for every earache.
No, definitely not. Surgical procedures come up too, like fixing a perforated eardrum, that's tympanoplasty.
Yeah.
Or if those little middle ear bones are damaged, maybe reconstructing them. Ossicular chain reconstruction.
More specialized stuff.
Yeah, ENT territory. And then, importantly, for cases where maybe the cause isn't easily fixed, or while waiting for surgery, or just long-term, there are hearing aids and bone conduction devices.
To help amplify or bypass the problem area?
Precisely. The notes can go into a bit more detail on some specifics, especially things relevant early on.
Okay, like what?
For wax, they recommend softening drops, like olive oil, then maybe irrigation, and they make a very clear point. Avoid cotton buds.
Yes. Everyone needs to hear that. They just push it in.
They explicitly say that. For otitis media, the notes state most simple cases get better on their own in, say, 1 to 4 days. So management starts with pain relief.
Paracetamol or ibuprofen?
Right. Antibiotics like moxicillin are reserved for specific situations mentioned in the notes, like if it's affecting both ears or if the eardrum is perforated.
Okay, specific criteria.
Yeah. And for that persistent glue ear, bilateral otitis media, with effusion causing significant hearing loss, the notes mention considering grommets.
Those little tubes?
Yeah, and referral to ENT for that. Similarly, for otosclerosis, since it often needs surgery, It's an ENT referral for considering stapes replacement.
Stapedectomy.
That's the one. And the notes also really emphasize hearing aids.
They're recommended regardless of severity.
That's what the notes say.
Yeah.
Because they directly amplify the sound to overcome that conductive gap. And they make a really important point about children.
What's up?
Early fitting is crucial for kids with significant conductive loss. You need to get them amplified quickly to prevent delays in their speech and language development, because that happens during critical windows.
That's a huge point, especially as we said, it's more common in children. Timely intervention is key.
Absolutely vital.
Okay, that covers management well. Finally, what about the long term? Do the notes touch on prognosis and any potential complications?
They do. The prognosis, as you'd expect, really varies. Depends entirely on the cause and how treatable it is.
Right.
For many causes, wax, uncomplicated infections, even some surgical repairs. The notes suggest that proper management can often fully restore hearing, or at least improve it significantly.
That's good news.
It is. But if the cause isn't treated, or if it's something irreversible, then unfortunately it can lead to long-term issues. The notes list complications like difficulties with communication,
Obviously.
which can then lead to things like social isolation, feeling cut off, and just generally an impaired quality of life.
Yeah.
It really highlights why getting the diagnosis right and managing it appropriately, like the notes lay out, is so important.
Absolutely. So wrapping this up, we've really walked through your MSRA revision notes on conductive hearing loss step by step. We've covered the definition, the causes, from wax to otosclerosis, the underlying mechanics, how it presents.
Yeah, those key symptoms like muffled hearing, maybe that weird hearing better in noise thing.
Right. And the bedside tests, RIN, whatever what you look for on otoscopy, the role of audiometry.
And then the management strategies tailored to the cause, including that crucial advice on avoiding cotton buds and early intervention for kids.
It seems like the thread running through these notes is understanding the cause is paramount because that dictates the investigation and the management.
Exactly. And distinguishing it from sensorineural loss, that's the foundation. Your notes provide a really solid framework for tackling this condition, whether it's for exams or when you see patients. Remembering those high-yield points we flagged, they often pop up.
Definitely. So for you, our listener, we really hope this deep dive, breaking down these specific notes, has helped cement your understanding. Hopefully revision feels a bit less daunting now. You've got the structure, the key details.
Yeah, this is all about pulling the essential info straight from the revision material you shared. Keep going over these points so they link together logically.
And to keep practicing, test yourself on questions related to this and other MSRA topics. Definitely check out PassTheMSRA.com.
Yeah, loads of practice questions there. And for even more resources, guides, and information to help your studies, also explore freemcra.com.
Great resources. Keep learning, keep revising that material.
And keep diving deep.